So thank you all for joining us for BrainMap today. As usual, the seminar series is co-sponsored by the P41 Funded Center for Mesoscale Mapping housed in the Martinos Center. And today we have the privilege of welcoming Dr. Veronica Clavijo Jordan, who is an assistant professor of radiology at Harvard Medical School and an imaging scientist at the Martinos Center. She earned her BSE in bioengineering in 2006 and a PhD in biomedical engineering in 2012 at Arizona State University under the mentorship of Dr. Kevin Bennett. Her doctoral research established a foundation in protein cage nanomaterials and MR relaxometry through engineering ferritin-based magnetic nanoparticles and chemically tuning their relaxometric behavior. She completed her postdoctoral training at UT Southwestern Medical Center in Dr. A. Dean Cherry's lab, advancing responsive molecular MRI for zinc biology, including sensitivity amplification via water exchange engineering and functional zinc secretion imaging. Since joining the Martinos Center in 2018, her lab has built a translational platform that treats regulated zinc secretion as a functional biomarker, so an organ-first strategy for earlier detection, stratification and longitudinal surveillance in pancreatic cancer, while expanding into redox and microenvironment imaging in liver and fibrosis relevant contexts. So please join me in welcoming Dr. Jordan.
Thank you. Thank you for that introduction. It's really nice to be here, although I've been here for a while, but first time that I'm doing a BrainMap. I'm happy to give this story that I actually haven't given this story as this complete, like with an evolution up to this point. So bear with me if it goes a little long, hopefully not. So in order to image, So this talk will center around the development of a platform that we developed to image organ function. And for that, we start by understanding certain roles that secretory organs have in the body. So for example, in the endocrine pancreas, an increase in blood glucose initiates the release of insulin from pancreatic beta cells for glucose metabolism. In the exocrine pancreas, an increase of the secretagogues, cholecystokinin, and secretin initiate the release of digestive enzymes and bicarbonate for digestion. And we also found that in the prostate gland, an increase in glucose in the blood actually initiates the release of its functional components like proteins and citrate for fertilization. Now, all of these processes have one unifying theme, and that is that zinc is commonly co-secreted as a response to stimulation by a secretagogue. So in order to be able to use that secreted zinc as a surrogate of function, then if we can have zinc-sensitive probes, we would be able to potentially see that. So when I was in Texas in Dean Cherry's lab, we developed these a library of different sensors. In this case, I'm showing here two zinc-sensitive probes that are gadolinium chelates with a zinc binding arm, and where the length of this chain determines how the affinity towards zinc, in this case, this gadol-1 or this higher affinity to zinc binds more tightly, and this lower affinity probe binds less tightly. So the idea is that once it binds to zinc, then forms this larger molecule with albumin, and that changes the probe from a low relaxivity, low signal intensity agent when it's unbound to a higher relaxivity, high signal agent when it's bound. That can be illustrated here in this image of a phantom, where you have the same concentration of probe and albumin incubated on all four, but an increasing concentration of zinc, and you see that the signal changes and increases proportionally. So to image endocrine function, then one could design an experiment in which if we take a fasted mouse and we give glucose IP to this mouse, one would see then an increase in blood glucose and an accompanying increase in insulin. Now, if we give the zinc probe at the same time, then potentially we can see that those secretions as enhancements in the gland locally. So I don't know if any of you have experienced imaging the pancreas of a mouse. It's not an easy organ to image. It's pretty amorphous, and it's actually intertwined in the abdominal organs, so it's difficult to locate and image consistently the same piece of tissue over time. So what we did is we actually fixed the organ to these 3D printed MR compatible pancreatic imaging windows. And what we do there is you pull out the pancreas and you fix it onto these petals. And now I'm able to prescribe an imaging slice across, or imaging slices across the tissue consistently and image that over time. So we use the two probes that I mentioned before, a high affinity one and a lower affinity one. You see that in the pancreas. Even without any glucose stimulation, you still see some enhancement in the back as a background with the high affinity, and with the lower affinity, you don't see that much background enhancement, and that can be seen here in this quantified plot. But now when you give glucose, you can see that with the high affinity agent, the enhancement is everywhere, basically, is quite high. And with the lower affinity agent, you see more patchy, more hotspot type of enhancement, which is really more what would be expected, as the islets in the pancreas are distributed very sparsely in the organ. And also you see that a higher affinity probe binds tightly and actually stays there longer, whereas the lower affinity probe enhances as after administration and secretagogue injection or glucose, and then it washes out faster. That can be seen here, where if we can now take the tissue and section it, we can actually do our best to co-register it to its accompanying MR slice, and you see that the distribution of beta cells or islets here on the shown as red dots here on this H&E, and superimposed here on this MR slice, that the distribution of those islets actually tracks with the enhancement that was seen with MR. So really showing that these hotspot enhancements in the mouse after glucose stimulation is more representative of this local release of insulin along islets. So as I mentioned, how this the mouse pancreas is really not similar to the human, is not a solid organ. We decided to image and do a similar experiment in the non-human primate, and this was done at Merck labs, actually. And in this experiment, what we did is we infused two different probes, so a zinc-sensitive probe and a non-zinc sensitive but still albumin binding gadophosphat probe, and it's infused for roughly an hour. And during the first 20 minutes, there's only a saline infusion. During the next 20 minutes, it's a graded glucose infusion on the cannulated primate. The first 20 minutes, it's a mid-level dose, and then the last 20 minutes is the highest glucose dose. Along all the protocol, we're collecting serial blood measurements and also collecting serial T1 weighted scans. So as I said, the pancreas of the primate is much more similar to a human, much easier to locate. And we see on the top on the first study where the zinc-sensitive probe shows that over time, as the graded glucose infusion is being given, the signal in the gland enhances. But we also see that hotspot type of enhancement and not really a bulk organ enhancement all throughout. Now, with the gadophosphat or non-zinc binding control, we don't see the same level of enhancement. So here we prove that the zinc-sensitive agent generated these focal pancreatic hotspots during the greater glucose infusion, and that a non-zinc sensitive control gadolinium showed much less. So this established that regional beta cell functional imaging was feasible in a large and clinically relevant pancreas. And importantly, that the phenomenon was not restricted. And by phenomenon, I mean the fact that zinc is co-secreted with insulin, that this phenomenon is not restricted to the mouse pancreas, that this can be also seen in the non-human primate pancreas. Now, as I said, that we were collecting blood measurements. We can now quantify that information. We see that on both studies, the glucose was infused equally, so there was not a difference there. But what was interesting is that on the study that was receiving the greater glucose infusion at the same time as it was receiving the zinc probe, there was an increased amount of insulin secretion and C-peptide secretion relative to the non-zinc binding control. So the study suggested that this zinc-sensitive agent might actually perturb endocrine signaling, and this was the high affinity probe. So that is a very important translational consideration. Now, how well does this zinc MRI track secretory dynamics? So we took these same blood measurements and then co-registered or correlated them to the area under the curve of the hotspot signal. And we were able to see that only with the zinc-sensitive probe that we can track the amount of insulin and C-peptide secreted to the amount of signal change in those hotspots. And we couldn't do that with the non-zinc sensitive control. So then this letting us believe that the informative unit here are these functional hotspots and not really the mean pancreas signal, because mean pancreas signal was not showing that correlation. So then we move to the next organ that we can image its function. And this was really an incidental finding because we didn't really know that the prostate could be stimulated to release its components. But when we were scanning the endocrine pancreas of mice, we saw that actually on mice that were stimulated, that there was a large and significantly bright enhancement in the pelvis. And so we decided to repeat the same experiments where we were giving glucose IP to fasted mice. And we would, see this increase in blood glucose. This case, we don't really know what is co-secreted, likely citrate and other proteins for fertilization. But what we saw is that when we perform the stimulus and give the zinc probe at the same time, the prostate here of the mouse enhances quite significantly. And that we concluded that it was zinc specific because no zinc, non-zinc binding control did not show that enhancement. And only glucose stimulated animals show that level of enhancement. So to understand what could be happening or what is the mechanism of detection here in the prostate, we decided to take the prostate glands of animals that were stimulated with glucose and not stimulated with glucose, and that also received the zinc probe IV. So this is the prostate gland of a mouse that was not stimulated, so in its quiescent form, and that it received the zinc probe IV. So we can look at the glands here in the lateral lobe, which are known to contain high secretions and high zinc. We can see that with XRF or X-ray fluorescence, we can delineate the different membranes by looking at phosphorus distribution. We can also look at where the gadolinium distributes and where the zinc distributes relative to the probe. So in this case, this is without stimulation. Clearly, the zinc is confined in intraglandular space, and the probe is distributed outside the gland. So that's why we don't see enhancement. Now, what happens when we take mice that were stimulated? And these ones, we see that there were already changes or differences in the architecture and the structure of these glands. So they look contracted, And then when we see the distribution of the elements, we see gadolinium is still distributed outside, but we also see that after stimulation, the zinc is actually distributed outside the glands. And that's why we see that high enhancement in the gland, because the probe doesn't readily enter cells. So this zinc needs to be made available. So when it's stimulated, it's secreted, binds to our probe, binds to albumin, and forms this high relaxivity complex that gives that really bright enhancement. So we capitalized on the fact that zinc content is known to be significantly lost in prostate cancer, and this is in the tumors. So we leveraged that loss to detect prostate malignancy with zinc MRI. And here this is an H&E slice of a mouse bearing a tumor on a transgenic adenocarcinoma of the mouse prostate model. And you can see the tumor itself is highlighted here on the zinc map, that the zinc level is lower than the remaining gland. You can also see the distribution of gadolinium. So when we compare the healthy prostate to the tramp prostate, the healthy prostate has pretty high enhancement after stimulation, but the tramp prostate, the tumor does not become secretory, is not secretory, and the remaining gland also has reduced secretory capacity, and that can be captured by MRI when we provide the zinc probe and the stimulus. But then going back to imaging the other secretory organ, in this case, the exocrine pancreas. So similarly, we take a fasted mouse and we administer the secretagogue, in this case, cholecystokinin and or secretin. These initiate the secretion of enzymes for digestion. So we would see that increase in blood. But if we administer the zinc probe at the same time, then potentially what we would expect is that we would see the pancreas enhanced all throughout, because the exocrine gland, conversely to the endocrine gland, the exocrine is really the majority of the pancreas gland organ. So if there is a tumor, then potentially we would see this sort of image enhancement, because once zinc is secreted, the zinc would bind to the probe, which then would bind to albumin. And we wanted to then now use all that information that we have to a clinical use case. And the clinical motivation, or the clinical use case that we chose, was using zinc MRI to detect PDAC, or pancreatic ductal adenocarcinoma. And the reason for that is that PDAC has a 5-year survival of less than 12%. And this is mainly because it is usually detected at a very advanced stage, where only less than 20% are resectable. And even on those that are resectable, about 80% experience recurrence within 5 years. Now, to those patients that have recurrence, usually the options are chemoradiotherapy, which are very aggressive treatment protocols, and they're surveilled via imaging. Now, incidental findings of tumors in the pancreas that are found for other reasons, that are found on patients that were scanned for other reasons, they found that tumors less than 10 millimeters in diameter result in actually a 5-year survival of 60%. So that really highlights why, having a way to detect early is crucial. But the current diagnostic protocol is CT, is MRCP, or magnetic resonance cholangiopancreatography, blood CA19-9, endoscopic biopsy. These have very poor performance at differentiating PDAC from pathologically benign conditions. And pathologically benign conditions, such as pancreatitis, for example, carry the similar clinical symptoms that PDAC would. So there's really a need for sensitive imaging that can be used for early detection of PDAC onset, for assessment of treatment response, and for surveillance of PDAC after recurrence, once the treatment is stopped, for example. So we developed this PDAC model here, where we inject pancreatic cancer cells directly into the pancreas of an immunocompetent mouse. We allow those tumors to grow for 1 and 2 weeks. And then we perform this stimulation zinc MRI at 1 week and 2 weeks. And here we can see the characterized tissue, where at 1 week the tumors are fairly small, and then at 2 weeks the tumors grow quite fast. So in this experiment, we tested a panel of secretagogues. And the secretagogues that we screened were cerulean, which is a cholecystokinin analog, to stimulate acinar cells. And then secretin is another secretagogue that stimulates ductal cells. And in combination, we can combine those two and give those as a cocktail, and that would then presumably maximize the amount of secretion in the exocrine pancreas. So we found that the healthy pancreas actually does not really exhibit a large secretory secretory signal. We gave here on the top healthy mice that received the zinc probe and saline. So yes, there's no signal in the pancreas. We gave cerulean as the cholecystokinin secretagogue, and there's also not really a lot of enhancement in the gland. So was a little puzzled, and we imaged the animals that were bearing tumors. So the animals that were bearing a 1 week tumor actually showed that the pancreas gland then showed enhancement, and the same thing happened with the 2 week tumors, meaning that this is a secretory, hypersecretory signature that is only, at least here, seen on a tumor-bearing pancreas. So then we tested the other panels, the other secretagogues in our panel. Secretin showed that the 1 week and 2 week tumors also showed enhancement, and that combination of cocktail, secretin plus cerulean, showed the maximal enhancement in the gland. Now, notice that we're not looking at the tumor, really. We're not necessarily that interested in tumor imaging because that is not the functional readout. The functional readout here is the surrounding, quote unquote, healthy pancreas. So in an MRI scan of a patient, I don't have to look for the tumor. I can do that by just looking at the pancreas, which is much easier to locate. We quantified all those signals, and we saw that both cerulean and secretin had some differential levels of enhancement depending on how evolved the tumor was. But both of them, when given as a combination or as a cocktail, the signal was boosted for both groups. The tumors that had a 1 week old tumor versus the 2 week old tumors. So we characterize the expression of zinc transporters in tissue by IHC. Now, zinc transporters are these membrane-bound proteins that, in this case, ZIP3 and ZIP4 are transporters that import the ion into the cell, and Z and T1 are transporters that export the ion outside the cell. So essentially giving us a snapshot of zinc trafficking or flux. And we see that only in the tumor-bearing pancreas, there was quite significant upregulation of these zinc transporters at 1 week and 2 week tumors relative to a healthy pancreas for ZIP3, ZIP4, and the export transporter. So then we concluded that these 3 transporters are upregulated in the tumor-bearing pancreas compared to healthy. Now, to test how specific is this signal or this secretion to malignancy when we compare to pathologically benign conditions, as I highlighted earlier, that pathologically benign conditions such as pancreatitis can be confounded for PDAC clinically. So it's important to differentiate that, to see whether our imaging technique can differentiate these two pathologies. We generated this model. It's a surgical acute pancreatitis model where the neck of the pancreas is ligated, meaning ligating the pancreatic duct, separating the pancreas into 2 segments: the pancreas tail, which becomes severely inflamed, and the pancreas head, which stays again also quote unquote healthy. So that means that in one single MRI scan or one mouse, I can promote the stimulus, give the zinc probe, and see whether both segments enhance or don't enhance, or enhance separately. And what we're able to see is actually that they are not. So this phenomenon does not seem to be observed in the acute pancreatitis pancreas, meaning that the ligated inflamed pancreas does not show this increased stimulated zinc secretion. Now, how about chronic pancreatitis, which is now the chronically inflamed pancreas? In this case, we took mice that were stimulated with really high doses of cerulin, 6 doses given separated by an hour, and given for three times a week for 5 weeks. So by week 1, the pancreas still remains normal. Week 3, we start to see inflamed pancreas, and week 5, we have a severely inflamed and atrophied pancreas, and that can be seen by a reduction in blood in pancreatic volume. So when we perform the secretory stimulus and the zinc probe MRI on these animals, we see that the chronically inflamed pancreas does not show a change in signal intensity compared to vehicle control. So that allowed us to conclude that the chronically inflamed pancreas does not exhibit the same stimulated zinc secretion signature. So we then wanted to test the ability to detect treatment response using a newly developed or newly class of cancer drugs that they're called KRAS targeted drugs. In this case, we collaborated with Mirati Therapeutics, which that was then taken over by Bristol Myers Squibb, and they had this KRAS G12D inhibitor that was very effective preclinically. We got in contact, and I asked them, hey, can I take some of your compound and test it in my imaging techniques? And they were like, yes, absolutely. I thought they were going to be a little more resistant, but no, they're freely giving it away. So in this paradigm, now mind you, this drug specifically at the end of their trial had to be withdrawn because of suboptimal pharmacokinetics. But there is a whole list, and there's a race right now for who is going to come up with this new miracle KRAS drugs, with RevMed, for example, being very next in line, and we're actually going to test their compound with our technique too. But in this, with KRAS, with the Mirati drug, what we did is we had these PDAC mice that we allowed the tumors to develop for 12 days. Then they were treated for 17 days. And throughout the treatment, we then performed our stimulation and imaging paradigm at 3 to 5 days post-treatment, 10 to 12 days, and 16 to 17 days after treatment. Then the treatment was withdrawn. And then we performed the same stimulation paradigm after treatment was withdrawn to look at cancer recurrence. What we're able to see is that, one, that the treatment is very effective in mouse models. So the top panel is vehicle-treated mice. So you can see that the tumors are huge. The very little pancreas that's left after stimulation and secretagogue, after zinc probe administration and secretagogue stimulation, shows very high enhancement, meaning corroborating our previous results that when cancer is present, the surrounding pancreas is hypersecretory. Now, after 3 to 5 days post-treatment, these animals were received the zinc probe and received the cocktail to stimulate their secretion. Now, you can also see that the tumors are very small, so the treatment is definitely working. But the change in signal in the pancreas after stimulation is not present. So that being consistent, that this hypersecretion actually does track with treatment efficacy. And the saline-treated groups also showed no signal enhancement in the pancreas. Here you can see how by tumor volume measurements, so more crudely imaging the treatment response, clearly the animals that received the vehicle grew very fast, and the animals that were treated were very small in size. And that the signal change in the pancreas, not necessarily the tumor. So here, I don't need to know where the tumor is, but the pancreas really tracked the response to treatment. And even within the last week, we start to see potentially some recurrence. Now, that's a very big problem in the KRAS world, where these drugs are now fighting the fact that resistance emerges almost inevitably. So being able to track that or to see that non-invasively and as early as possible can be very important, not just clinically, but also in clinical trial design. But now we characterize the zinc transporter expression on these groups, and we saw that yes, all zinc transporters are upregulated in vehicle, but also on the treated ones. So that was a bit puzzling. So at least what we know is that zinc MRI does detect the response to KRAS G12D inhibitor treatment, and as we can detect that as early as 3 to 5 days post-treatment. Now, what happens when we withdraw the treatment? So when a patient shows efficacy and then the treatment is withdrawn, how long can we wait and how fast do we see that cancer recurrence? In this case, we treated these animals up to the point where treatment efficacy was attained, and that was for 2 weeks. So pre-withdrawal, you see in this example, the tumor was completely regressed. So that disappeared. And after stimulating these mice with the secretagogue cocktail and receiving the zinc probe, you can see that pancreas does not show that hypersecretory activity that it does when malignancy is present. So this gives us the indication that the treatment is keeping the cancer at bay. Now, when we withdraw that treatment, we saw as early as 1 to 3 days that the tumors come back. You can see the tumors here growing, but also does the signal in the surrounding quote unquote healthy pancreas that indicating, hey, malignancy is coming back. Now, in this case, of course, you can also see the tumors, so you don't necessarily need this very sophisticated technique, but in humans, the time scales are different. And then the longer the withdrawal period is sustained, the tumors are larger, and so does the surrounding pancreas show very significant enhancement after stimulation. Here you can see that tumor growth during treatment and after withdrawal. And you see the interesting thing was that we see this divergence where the animals that were followed by imaging. This was longitudinal zinc secretion stimulation. The ones that were stimulated, those tumors were actually smaller than the ones that were not stimulated. So indicating that there might be some hindrance of recurrence by stimulating zinc secretion. Similarly, we quantify the signal intensity in the tumor-bearing pancreas, and that cleanly matched the growth patterns. In this case, after withdrawal, the zinc import transporter seemed to be sensitive to that regrowth of cancer. So zinc MRI detects recurrence after KRAS inhibitor treatment as early as 1 to 3 days. And that zinc probe and secretagogue cocktail might have some ability to hinder recurrence that we're trying to investigate. So then we wanted to evaluate the ability to detect this unique increase in zinc secretion in human PDAC. So would we see the same things in the human pancreas? So what we did is we took about 20 human PDAC specimens, and we had our pathologist, Dr. Stuti Shroff, highlight the different segments of the tumor margin and give us an assessment of what the categories of tissues she found. So we had benign tissue, so tissue that histologically looks normal. We have malignant tissue and this chronic pancreatitis-like tissue that's secondary to malignancy. And we stained those different segments against, we set the entire pancreas, but we quantified the different segments for ZIP3, ZIP4, and ZNT1. So our import transporters and our export transporters. And what we're able to see is that in the human pancreas, these transporters are also upregulated in the malignant sections So malignant tissue and a chronic pancreatitis-like tissue in the presence of malignancy. So these transporters are upregulated very much like in the mouse, in the human pancreas too. Yes, yes, yes. It was surprising. And it was a nice, interesting conversation I had with her because I said, well, what do you mean chronic pancreatitis like? And yeah, histologically, it shows similar characteristics, but is 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 malignancy secondary to malignancy? So whether this same upregulation would be seen in the chronic pancreatitis non-malignant human pancreas, we would have to evaluate that on different cohorts. But at least in the mouse, we don't see that. But here, the histologically, the human PDAC is quite complicated and different than the mouse, which is why we always want to go back and forth with human tissue, back to mouse, human tissue. So along the same lines with here with Marianne Lefeur, what we did is that we took then tissue, pancreas tissue from human Whipple surgeries here at Mass General. We took, and this is from, I'll show the result of one patient. We take that tissue, we can keep it viable and alive. And the idea is then that we would take that, quote unquote normal, and then we take one section and we take the adjacent section. We then stimulate one section and we don't stimulate the other section. We wash out the supernatant and then we see what's left. So presumably what's left would be in the secretagogue stimulated tissue. It should have lower zinc than the adjacent that is not stimulated. So we've tried to see that difference. And we use laser ablation ICP right down the hall, where Marianne and Chloe scanned this tissue and we were able to look at the difference. So in terms of zinc content, we were able to see that the zinc on the non-stimulated human pancreas had 200 ppm more than the secreted. So then we were able to also see or corroborate, well, is that just leakage or leaching because of ions leaching out? The manganese, which is known to be present in the pancreas, did not show that difference in between secreted tissue and non-secreted tissue. So really highlighting that this is zinc specific. So a take-home message then of this is that this platform really matured across organs and species. So we started first looking at the mouse pancreas for endocrine imaging, then the prostate, then non-human primate pancreas. And each of these steps really de-risked a different part of the problem. The decisive variable is regulated zinc trafficking. So what matters most is this stimulus evoked efflux, where zinc moves, and not really total tissue zinc alone. And now in PDAC, or in pancreatic cancer, that biology becomes clinically relevant. So the assay supports this early detection logic, benign discrimination, and fast readouts of pathway targeted therapy and recurrence. And that takes us to this, take home sentence or mantra of stimulated zinc secretion MRI then turns a metal into a readout of organ function. So I'd like to acknowledge really everybody that contributed to this evolution of many years, many institutes, where the whole concept of zinc secretion MRI started in Dean Sherry's lab when I was a postdoc. Then I came here and extended this into PDAC, and I've been really actively trying to pursue this into clinically use imaging technique. And for that, I'd like to thank everybody that's here that contributed to this, along with my funding sources, and of course you for your attention. Thank you.